This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. A 60-year-old man presents with this situation. This patient has undergone cataract surgery elsewhere 3 months back, and he presents with history that he can't see well. The reason is obvious. He has a decentered lens. And this is the situation. So I need to explant the lens and put in another lens. So what are the things which are going in my head right now? So I'm not sure. The patient doesn't have the records. I'm not sure what lens has been put. And I see some amount of iris atrophy in this region. The pupil is irregular. And obviously there looks to be a posterior capsular tear. And the lens is decentered. So my initial suspicion is that there is a PC tear, and that's the reason why the lens is decentered and the vitreous wasn't managed appropriately. That's my thought. I don't know what lens has been used, and I also don't know the procedure which has been done. It looks like probably a fake emulsification. So at this point, once we closely look at the eye, some of the features which we need to notice here is what does this iris atrophy suggest? Probably this looks to be injury to the iris during the surgery, either phacoenergy itself causing iris chafing, or there could be a shalling of the chamber or the iris getting caught in the wound when the surgery is being done. And obviously there is a PC tear, and the lens is not in the bag, it is decentered. That's all information we can get now. So my plan would be to explant the lens, do a vitrectomy, and then consider placing a lens. The lens options would be, number one, if it's possible to place an IOL in the sulcus, I would be placing a multi-piece lens. And this doesn't look to be a multi-piece lens. If this is a multi-piece lens, and if it is alright, then maybe I can consider placing it in the right position, provided we have a good anterocapsular axis support. The issue here is the pupil is not well dilated. I'm not really able to see the anterocapsular margins very well. So in the situation, the second option would be, if I'm unable to have enough support to place the posterior chamber lens or the anterocapsule, then maybe I'll consider an iris clip lens. That is my plan as of now. And let me begin the surgery. I'm not sure what lens has been used, and that's the reason I'm going to use a scleral tunnel incision, make an initial incision, and then use a crescent blade to create a tunnel. The tunnel would be about 5mm or 6mm. The idea is, if in the situation where I am forced to use an iris clip lens, I can use the rigid iris clip lens through this incision also. Okay, and now let us discuss a few principles of surgery. Now, before trying to pull the lens out, it's always important that you rule out any vitreous prolapse near the lens, because when you're trying to pull the lens out, you shouldn't pull the vitreous, because that is going to cause traction on the vitreous base and can cause a retinal tear. So before engaging the lens, it's always important to check for vitreous and do a limited vitrectomy around the lens and then pull the lens out. That would be the ideal situation. So I'm going to use diluted triamcinolone acetate to just check for vitreous. There seems to be evidence that the vitreous strands are present. So a limited anti-vitrectomy is being done, just enough to clear the vitreous around the lens, that's all. This ensures that we don't pull or tug at the vitreous. Then under cover of the viscoelastic, I just want to examine the lens first. I'm just maneuvering the haptics out of the bag and into the antechamber, and to my surprise, I realized that one of the haptics of the lens is broken off. It's almost amputated. So this lens has got only one haptic, and it was very easy for me to remove the lens. And now I need to do a vitrectomy. In this case, I'm using an AC maintainer. Because the eye would be slightly soft, I fill in with OVD and then make a paracentus incision in the opposite quadrant and then fix an AC maintainer. And now I'm going to do the anterior vitrectomy. I'm going to use the 23G cutter through the 2 paracentus incision. So we have a double infusion, one infusion from the AC maintainer and second would be from the vitrectomy machine as itself. The bottle light is kept low. We don't want unusually high infusion pressure to get in. It takes maybe a few minutes for me to clear off the vitreous around the area. We don't want to do any extensive vitrectomy, just enough to clear around the area. Now is the time to evaluate whether I have got enough support in the form of the anterocapsular margin. So I'm using a Y-hook to retract the iris and just to visualize. As we can see, after 3 months of the primary surgery, there is some amount of fibrosis of the capsule, which is good actually to provide support. But in the subincisional area, I am seeing that there is posterior synechiae, there is no space. So I'm using an iris spatula to gently remove the adhesions. So the flat spatula gets in and try to remove the adhesion. And at this point, I notice some vitreous fibrils. I go back and again do my vitrectomy. Mind you, I'm very close to the anterocapsular edge as well as the iris. I don't want to chew them off inadvertently. So the one trick is to use a very low flow rate so it doesn't tract any of the structures towards you. And I also use the cut in a linear fashion so that I can really control the amount of cutting which I want to do, which should be very less as I'm very near to any structure which I don't want to cut. Again, the iris spatula is used from the other side port just to ensure that all the posterior synechiae is broken and cleared off. See, and all these maneuvers are being done with the AC maintainer on. So this helps me because it's easier to do when the fluid is going into the eye rather than a softer eye. And if we use just OVD, it's going to go into the vitreous cavity. So in this way, to maintain the chamber and to maintain some degree of firmness, the AC maintainer does help. Again, I'm using an Y-hook just to ensure that the entire space in the ciliary sulcus that's above the anterocapsule is free enough for me to negotiate the lens into the bag. So one last time and go in with my cutter and clear off any vitreous. So now is the time to place the lens inside. So the pupil is small. I've used adrenaline in the saline just to try to dilate it. It doesn't really budge much. At this point, I had thought of, using an iris hook to retract the iris and see. But I thought with my second instrument, I can negotiate the iris to visualize. Although usually I use cohesive OVD during placement of the lens, in this case, I'm going to use the AC maintainer fluid itself to place the lens. So the AC maintainer is kept on and the chamber is being maintained by the fluid coming through it. My left-hand instrument retracts the iris and the distal haptic is placed over the rexus margin under direct visualization. Once the distal haptic is safely placed over the rexus margin, the trailing haptic is then dialed in. So during all these maneuvers, the chamber is well maintained, and now I can confirm that the lens is well centered with both the haptics in the ciliary sulcus above the anterocapsule, and it looks to be safe. I'm just checking one more time for any presence of vitreous. At this time, the AC maintainer is turned on. The pupil is slightly oval. That is because of the iris having been eaten off by the phacoprobe, or there was an iris burn. There is iris chafing. So now it's time to close. I'm using an atovicryl suture to close the scleral tunnel as well as the conjunctiva, and it's going to get absorbed, so it's not going to be an issue. So now the eye is closed. Intracameral antibiotics are placed into the eye, and that's it, the surgery is done. So these are the third post-op pictures. There is some inflammation, but the lens is well centered. The patient has got a good visual recovery. His vision is about 6/18. We have a residual refraction of -1 spherical. Maybe the biometry was not spot on. That's it, the case is done. To summarize, I think we need to have a couple of plans ready when you're faced with an unusual situation like this. So in this case, I was ready to put in both a sulcus lens with a multi-piece lens and as well as an iris clip lens if I didn't have any support to place the lens inside, or you could have used in a Yamane or a scale fixated lens as well. But when you're trying to explant the lens, always ensure that there is no vitreous around the lens before you pull out the lens, because we don't want to induce any traction in the vitreous space that we should be mindful of. So that was it. Thank you for watching and hope you found this helpful.